Well, good afternoon, everyone. Welcome to SADS Facebook Live number 78. This is unbelievable. Great to get to be with you on this Friday, November 19th, the year 2021. I'm Mike Ackerman, genetic cardiologist here at the Mayo Clinic in Rochester, Minnesota. I serve as director of Mayo Clinic's Windland Smith Rice Genetic Heart Rhythm Clinic and its complementary Windland Smith Rice Sudden Death Genomics Laboratory. As we are on almost every Friday, I'm here on behalf of Alice Laura, the CEO of the Sudden Arrhythmia Death Syndrome Foundation, the SADS Foundation, where I've had the privilege to be along her side since a while now as president of the board. So we've been doing this together, as you know, since about February 2020 of the COVID-19 pandemic, and we're still in it. Hang in there, everyone. We can do this. Mask when you need to. I have mine. Wash your hands when you need to. Get vaccinated as you should. I've been vaccinated and I got boosterized with my vaccine. Pfizer was mine last week. So do your part. And as you saw, some of the most recent information, you are far more likely to be hospitalized if you've been unvaccinated. But there are hospitalizations happening among the vaccinated, particularly those where the vaccine immunity has waned because it's been longer than 6 to 9 months since you were last vaccinated. So when you're eligible for the booster, and if you've been told you should get the booster, get the booster. Let's do this. We can do this and get things back to normal. I recently had a neat event where I couldn't show a picture because I was outside close to 6 feet. We didn't have masks on, and somehow that was captured as a violation. So I think the sooner we get on top of things, the more normal life gets to begin again. So press on, everyone. Hang in there. It's great to see those of you joining. Leah, glad to see you. And I think you're going to really like our conversation today. The monologue is over right as of now. And instead, Erin, through her magic, and she's an incredible member of the SADS team, is going to be bringing on a friend of mine, Brittany Hansen. And Brittany Hansen has a master's degree, her MS degree. She's a certified genetic counselor. That's what the initials next to her name, CGC, stands for. And Brittany is a cardiovascular genetic counselor as well. Not just a genetic counselor in general, hailing from Madison, Wisconsin, where my granddaughter lives. So I'm a little bit partial to Brittany already because of that. And so she's will tell us a little bit about herself, and then we're going to be discussing some things, really important things to save lives. So I think, Erin, yes, look at that. And here's Brittany, and you saw I told you those letters after her name, MS and CGC. So Brittany, welcome to the 78th edition of SADS Live.
Thanks for having me.
It's great to have you. Now, I know you're with Invitae, one of the largest genetic test companies in the world, based out of San Francisco, I think, is headquartered. Yes. But you didn't start your life with Invitae. Give all of us here in the SADS community a sense of how Brittany Hansen got from here to there.
So I started my genetic counseling journey actually in Cleveland, Ohio. I have my master's degree in genetic counseling from Case Western Reserve University. And after graduating there in 2012, I took a job at the Cleveland Clinic where I was a full-time cardiovascular genetic counselor for 8 years. Learned a lot, but family caused me to need to relocate. And so in March, I took a job with Invitae and have been there in their genetic counseling services team. So what we currently do is provide complimentary, so free of charge post-test genetic counseling to folks that have had genetic testing panels through Invitae. My sub-team focuses on cardiovascular panels, but also some of our hereditary cancer panels and proactive health panels. And there's a couple other sub-teams as well. So I've been doing that since March, and I love it. And I love being able to connect with folks all over the country.
Well, it's great that you do that, Brittany. And I think it's incredible that Invitae and other entities provide this free resource of post-genetic test, genetic counseling. As you know, I love genetic counselors. So a shout out to the genetic counselors out there. You know how loved you are, but you also know how few there are of you. And so tell us a little bit about just sort of the Society of Genetic Counselors. How many cardiovascular genetic counselors are spread throughout the country, the world, and why we've needed to provide a free resource like this?
Yeah, so I think, in the United States, so for the National Society of Genetic Counselors, in total, there are, I believe, 3,000 to 4,000 certified genetic counselors in the US. And then there's something called our special interest groups, and there's a cardiovascular genetics SIG or special interest group. And I believe at last count, there were maybe 200 to 300 of us. So, and not everybody focuses purely on cardiovascular. So we're still very much, a niche, but a growing one. And my numbers might be off. It's been a little while since I've looked at the SIG numbers of, participants, but a lot of cardiovascular genetic counselors wind up in large medical centers or academic medical centers where there are cardiologists that have, that special expertise, which makes a lot of sense. But as we all know, these conditions can affect anyone, anywhere, and not everybody is going to have the means or the opportunity to see, specialists like yourself, Dr. Ackerman. So, what we try to do is bridge that gap and make sure that if somebody's primary care doctor or, cardiologist who's less familiar with the SADS condition is doing genetic testing, that we're able to help them with the interpretation and management of those test results.
And I think that's so important because there's just not enough of the cardiac genetic counselors. And I think this multiplication that you've done was a pretty impressive strategy. Thankfully, I have 2 cardiac genetic counselors on the Winland Smith Rice Genetic Heart Rhythm Clinic team, but that's just not the norm out there. And so every family needs good genetic counseling. It's ideal if it's done by the genetic counselor. And I think I'm grateful that this is a resource that Invitae has provided. But let's leave Invitae and just turn our attention to the fact that we're halfway through November. November has been declared by, in the United States anyway, for those who joined us, like Erica from Germany. In the United States, November has been declared by the Surgeon General and the CDC as Family Health History Month. And as Family Health History Month, we really wanted you to help us sort of discuss the importance of know your story. So when you have symptoms of concern, know your story, tell your story to your healthcare provider, but also as important as your own story is know your history, as in your family history. So why are we caring about Family Health History Month so much anyway?
Especially within cardiovascular genetics, having a good understanding of an individual's family health history can really help their providers in clarifying their own personal diagnosis and ensuring that people are getting the right kind of workup for those cardiac symptoms. Since we're talking to folks within the SADS community, I'll focus more so on that. If a person is diagnosed with something like long QT syndrome, recognizing if they have a family history of sudden unexplained deaths or drownings, things that, again, support this having a hereditary component can ensure that they are getting a proper diagnosis, but that we can also help get them the resources and information for family members to get accurate screening and healthcare themselves. So it's really a 2-pronged purpose, identifying other folks within the family that might be at risk, but also helping get the individual patient the right kind of care.
Yeah, that is so important with this family history, but sometimes it's challenging, isn't it? And there's reluctance that we encounter. There's some hesitancy. How have you learned to help families understand the importance to gather this information, to break down some of the barriers. Oh, I can't tell anybody, I'm the black sheep. All of the things that you probably have encountered, every reason, excuse that has come up. So any pearls of wisdom here?
When I'm taking a family history or trying to gather some of that information, oh, sorry, knocked over my water bottle. What I usually say is something to the effect of, I'm trying to basically build the puzzle of your family. And the more pieces that you're able to provide for me, the better and clearer a picture that we can present to your healthcare provider. And so in sharing information both with your family members, so if you've been diagnosed with a SADS condition, disclosing that information and having to share the complexities that go with it can be challenging, and I do want to acknowledge that, but really stressing the importance that informing relatives of your diagnosis and encouraging them to let their own healthcare providers know and to seek the appropriate kinds of screening is really paramount in ensuring that people are getting accurate care. These are never easy or fun conversations to have. I think, one of the reasons that we really want to bring to light Family Health History Month is that, we're coming up on a lot of holidays here in the United States. You might have opportunity to be meeting and speaking face-to-face or via Zoom for some of us with relatives that you don't oftentimes get a chance to speak with. And maybe reserving some of that time to say, I've got some important information I want to share with you all. On the other side, gathering family health history information, both cardiovascular and otherwise, can be really beneficial when everyone's around the table. It can make it feel more like a conversation where everyone has the opportunity to share their own current health status and the things that they've been doing to address each thing, so that you can both gather that information and be aware, but also make it seem more like a conversational thing and not like you're trying to, get all of this incredibly private information for nefarious reasons.
Right. And I think too, it's helpful that the families realize that this is not just some sort of academic pedestrian exercise, but that this is actually a life-saving activity potentially. I've always been struck with the families when we take a family history, and as I always do, that they will tell you, so-and-so died. How did they die? Heart attack. And that's all the word we get. And then you try to unpack it and you say, well, what exactly do you mean by that 40-year-old who died of heart attack? And what do you do to help them get past the soundbite? Because they quickly learn that, wait a second, heart attack isn't maybe necessarily what I thought it was. And yet so many families, for any death, the answer has been, oh, they died of a heart attack. And you say, did they have coronary artery surgery before? No. Did they have a coronary artery stent? No. Were they having angina, chest pain, taking nitro? No. What exactly did you mean by heart attack? And then you discover quite something different when you do some pretty simple detective work. And so have you seen that? What's kind of the drill that you will do when you elicit a family history, so that at the Thanksgiving table, when they're chatting about the cousin or the aunt or the whoever, that they ask some details to get a little bit of a better picture of what exactly happened to that relative?
I think one of the most important things is just gathering like the circumstances under which that event occurred. Did somebody have chest pain that they'd been complaining about, went in an ambulance, was on the operating table and passed away, and the family was told that this was a heart attack? Or was this somebody that was found unconscious, did not regain consciousness, or who collapsed very suddenly? So knowing kind of the mechanism of what occurred in that way, trying to determine if an autopsy was performed. These are, again, really challenging conversations to have. And one of the things, even when I'm taking a family history as a genetic counselor, I'll couch with initially is, I apologize, I'm going to ask you very uncomfortable and prying questions. This isn't something I'm doing just for fun, but because the more, again, I can paint that picture, put together all those pieces, the clearer it's going to be onto whether this was what we should think of as a heart attack in the sense of clogged pipes, not a genetic arrhythmia or some kind of SADS condition that, there's a high chance that other family members could be at risk for. So certainly that's one of the factors. Also just gathering other risk factors. Was this a sudden death in an individual who had been a lifelong smoker with uncontrolled diabetes and hypertension and had pre-existing heart disease? I'm less concerned about that as a genetic counselor than I would be with somebody who was an adolescent or young adult, healthy, and who collapsed while participating in a sport or, had some other apparent very sudden trigger.
Yeah, I think the detail is incredibly important in painting the picture, as you said, assembling the puzzle, doing the detective work. I like our families to join me to become detectives in solving these sudden death tragedies. And so we'll often have the families go out on assignment so one of my strategies I have is I ask the families kind of an open-ended initially, are you related to anyone who's died before the age of 50? And then I take an accounting of every one of those deaths. Oh, that was cancer, well explained. Tragic, yes, well explained. That was the revolver had something to do with that death. Tragic, yes, well explained. But when those get the ones that are unsatisfying, we send them out on homework. Call the relatives. Sometimes they do it right in the office. Call the relatives, get to the next person closest to that person who died, and let's find out the why and the details. And then all of a sudden, there's an enlightened picture around the heart attack or the drowning or the unexplained car accident where it really was unexplained. They were the driver and they were not drunk and things like that. And so really picturing, and I know, the genetic counselors, you guys are some of the best at sort of having this detective-like mindset to get, just the facts and get the details.
Yeah. And that's something where I try to share some of those resources too with the patients on what questions they can ask. What's really important when you're trying to gather family health history is determining, how was this person related to you? I'm also guilty of calling very distant relatives cousins, but there's a big genetic difference between somebody's, first cousin and their second cousin 3 times removed that is by marriage. Like, no, that's not going to be super genetically relevant for us.
Right.
So knowing how a person's related to you, knowing the age they were at which they had that cardiac diagnosis, trying to gather exactly what that is. At my current role, I see lots of folks who themselves may not know what their own heart diagnosis is, and I'm trying to counsel them on a test result. So really, advocating for people to ask their providers, that point blank question, is there a name for what you're treating me for? Do I have long QT syndrome? Do I have Brugada syndrome? Or do I have an unexplained arrhythmia? Because again, knowing that information so you can also share it with your relatives and have them be able to say, cousin Susie has long QT syndrome, that's going to help their provider know what to do with that, versus cousin Susie's got something weird with her heart. I don't know, should I get checked out, doc? Like, that's going to be so very hard for your provider to know what to do with. So the more you can arm yourself with those very simple, what's the diagnosis? How old were they? How is it getting treated? That's going to paint that clear picture for yourself to share with relatives, and then for their healthcare providers to know what to do with that information.
Yeah. I know recently, as you probably have seen too, there was recently launched what's going to be a life-saving awareness campaign for one of our SADS conditions, hypertrophic cardiomyopathy, or HCM. And the awareness campaign is, could it be HCM? And the pillars of the Could It Be HCM campaign, they're about knowing your story. Do you have any symptoms of concern that should be viewed as potential warning symptoms for could it be HCM? If yes, tell your provider, get them involved. Don't keep that to yourself. And then the second foundational pillar for Could It Be HCM is know your family history. And in Family Health History Month, it's sort of, are you related to anybody who's died suddenly or unexpectedly before the age of 50? Could it be HCM? Yes, it could. Could it be long QT syndrome? Yes, it could. Could it be Brugada syndrome? Are you related to anybody, like you just said, Brittany, who's actually been diagnosed already with long QT, Brugada, any of our SADS conditions? If yes, my view, and now the view of the SADS Foundation for 15 years has been, if you check yes to family history with those items, that's a penalty box check mark, meaning you have to have that looked into, because that's no longer just information about the past. That may be vital, life-saving information about the present, and potentially even your present and your future. And so anything you would add to that as an emphasis, or say, how do we do it better? I mean, we can keep calling November Family Health History Month every November, but how do we get some action behind that for families to really do that and take an accounting of the family story?
I think one of the things that you can really try to stress with relatives is, sounding that rally drum. This is something that the more people we can inform and get safely screened and treated, the less likely it is that we're going to continue to have these catastrophic events in our family and people that are, fine until they're not fine. Dr. Ackerman, you just talked about, folks who have symptoms, and what I oftentimes will get if I'm seeing somebody who's had a family history of a heart condition is they'll be very cavalier, like, oh yeah, they had this horrible thing, but I feel fine. I have no symptoms whatsoever. And that's fantastic. But if you've never had an echocardiogram, an ultrasound of your heart, if you've never had an EKG, some of these conditions, as well as a lot of you probably on this know, you may not have any symptoms. And we can't rely on that lack of symptoms. And so really stressing to those relatives, like, I'm happy you're feeling great, but I want your doctor to take a look at your heart to make sure that the inside matches how you feel on the outside, and that there's not something lurking that can be treated and help prevent a person from having something like a sudden cardiac arrest.
How do you communicate to families what I would say is actually their responsibility when they do get diagnosed with something, that they proactively tell relatives? So I'm thinking of a particular scenario. I don't have very many of these examples, thankfully, but one that comes to mind is, we made the diagnosis of long QT syndrome. We found the root cause. We know exactly the genetic address. We have the diagnostic gold standard biomarker, if you will, to prosecute the relatives. Yes, you do. No, you don't. Yes, you do. No, you don't. And we tell the families, let the relatives know about this. And sometimes they do, but most of the time they do. Sometimes they don't. And in this particular situation that I can vividly remember, the next time I met the family is when some of the cousins in the family are now coming to me, because cousin Johnny, not the name, died suddenly. When, had the dots been connected, that information should have gotten over to cousin Johnny's family. We should have been able to have tested them. We should have found out that he had the genetic marker. And not only should have we saved his life, we would have saved his life, because the treatments, when we know the diagnosis is there, for many, many of our SADS conditions, are so incredibly effective that tragedies don't happen when we know of its presence. And so I'm curious, in your world and in the world of genetic counseling, how often do you encounter that scenario where the families just don't communicate the information or don't know how to? And then how do you help them make it easy so that they can disseminate that information to the appropriate relatives?
Yeah. I mean, one of the things I tend to do for a lot of families is focus first off on their immediate close blood relatives. Like, do you have siblings? Do you have children? Are your parents still living? Aunts, uncles, cousins? And saying, these are the family members that genetically share the most genes with you. They're closely related to you. They have the highest chance of having this same genetic mutation or this same genetic condition. These are the folks that you should share a copy of your genetic test results with if you've had testing that was positive, or share what your diagnosis is so that they can get screened. And then try to identify any barriers. If somebody says, oh, I've got an uncle on my dad's side, but we don't talk to him. Again, not always a comfortable conversation, but saying, okay, that's fine, but is there somebody in the family who is in communication with him that could get this info to him? I never want to make somebody feel like they need to make communication with a relative that would not be good for them. Not every family is perfect. And so we just want to make sure that nobody has to live with any sense of guilt of I should have done something. I should have made sure that information was shared. So right. I speak a lot of, just put the ball in their court. Oftentimes, whenever, as a genetic counselor, I'm disclosing test results, I write up a letter that summarizes what those results mean and calls out a little bit, this is important information to share with your family members. And I direct patients to physically give a copy of that and their test result. And I say, this is like the GPS address now for your family. We had to drive up and down every street on the neighborhood looking in all the houses for the broken window for you, but we found it and we now know the cause. We can plug this in now for other relatives. But if we don't have your report, we don't have a way of doing that. So getting that information in that way. And I know that at Invitae, we have resources on our website that also can be letters and things to share either with relatives, but also with healthcare providers that may not have a lot of experience or background in ordering things like genetic testing, just to make sure that people are getting the right thing. And then also I know that there's lots of resources through the SADS Foundation too, with trying to put together how should I share this information? What are the most important points that I need to be getting across to my family members? But I think, if you had to pick one single sheet of paper to share with them, if it's a genetic test result that has your mutation, your gene on it, that's going to be the most helpful tool then for those family members to start that process of getting care.
And then Diana has a great question. I'm looking at the questions that they're coming in, and everyone out there, you are amazing as always. You give great ones. And I'm going to pick a couple here, Brittany. She's wondering, is there a lab, and I know the answer, but she's asking it, that will test for long QT or other SADS conditions? She carries the long QT gene and wants her adult children to get tested. Is there a kit I can order? It sounds like an easy question, but honestly, it's such a common one, which shows that we still have work to do for people to realize that the days of research-based genetic testing for these conditions are so long ago now. I mean, the first clinical genetic test for long QT syndrome was launched in the United States in 2003. And yet sometimes families don't even know, how do I get tested? And so I'll let you take that, obviously, and you can say where you're working. You should be proud of it. I'm proud of the place you're at. So is there a lab that will test for long QT?
There is. Invitae does do genetic testing for long QT syndrome as well as many of the other SADS conditions, but there are also other commercial genetic testing labs. So while I obviously have ties to one company, I want to acknowledge that we are not the only place to do testing, and that sometimes knowing if you have had genetic testing in the past, tracking down a copy of your report to see where was that testing performed, is that a lab that still exists? Because especially for cardio testing, not all of these labs from many years ago are still available now. That can be a helpful first step. And then as far as, getting genetic testing done, there have been great steps since these initial discoveries of, say, the long QT syndrome genes to try to get clinical genetic testing into the hands of people that it's going to benefit the most. So one of the challenges that oftentimes comes up is the cost of genetic testing. If we think about back in the day when we were looking at, the 3 main long QT syndrome genes, and that test was thousands upon thousands of dollars, that's not the case anymore.
Yeah, 5,400 to be exact.
Yes.
So you're right. It's not 3 genes for 5,400. It's 150 plus genes sometimes, where the cost point is actually close to 0. So you can remove the 5, 4, and one of the zeros and be left with the other 0.
Right. So I can speak. So at Invitae, we have a sponsored, no charge genetic testing program called Cardio Detect that for some of our large cardiac genetic panels that look at cardiomyopathy and arrhythmia genes, that can be ordered by a healthcare provider, and there's no cost to you as the patient. That can be done both via a blood draw, like we classically think about for genetic testing, but we also have other ways to get DNA through things like saliva or cheek cells. So if a person has been hesitant because they're afraid of needles, or they don't have access to a way to, give a blood sample, there's other mechanisms to do the testing.
So Brittany, can I ask you there, specifically with Diana's question, I think what's really important about that is, let's say she has 3 adult children, and one's in Wisconsin, another's in New Jersey, and the third child is raising their family in Nevada. Do each of those 3 kids need to go to their own doctor, their own cardiologist, to get the genetic test ordered, or is there a way of facilitating the genetic test to determine, did I inherit my mom's thing, yes or no, without having to do all of those engagements? Is there progress being made in facilitating variant-specific genetic testing without it having to be done and ordered by the New Jersey doctor and the Wisconsin doctor and the Nevada doctor for each of those 3 adult kids?
So at this time, there does still need to be a healthcare provider that's ordering this genetic testing. There are companies that do telegenetic counseling. So either via something like a Zoom video chat or by phone, a genetic counselor will review a person's family history and the relative's genetic test result and ensure that, that testing is being appropriately ordered. That is one opportunity. But because this is at the end of the day still a medical test, knowing that there is somebody on your healthcare team that also has access to this report and is with working with you as a team to get the right kind of care for that is important. So it is a barrier that we recognize. So one of the things oftentimes I do is say, start by talking with your primary care doctor, see if they feel comfortable being the one to order this genetic test. And if not, here are the resources for how you can find a genetic counselor locally through the National Society of Genetic Counselors. Truly, if you Google find a genetic counselor, it's the first thing that pops up on the webpage. It's findageneticcounselor.com. But there are also companies that are able to do things via telehealth, so all over the nation. So again, just trying to make sure we can get these tests into family members' hands.
Yeah, and I know that with our program, for example, and you can comment whether that's a reasonable way of doing it, is if I'm taking care of Diana and me and my genetic counselor, we've established the family mutation for which we want to do variant specific testing, we could potentially be the source, right, to facilitate the test for the son in Jersey, the son in Wisconsin, and the daughter in Nevada, or that type of arrangement if they're all struggling to where their local internist says, I have no idea what you're talking about, which is often the case. Is that a model that's reasonable, or do you think it would be better to try to really get that patient brought to their local point of contact?
I think that really is going to depend on the context in the situation. If like a person's cardiologist feels comfortable being the ordering provider for those family members and may very well then become the managing cardiologist for family members that test positive, that can be a really beneficial, opportunity and way to get testing done. But that also, there's a lot of challenges, like technically those really aren't that healthcare provider's patients. And is that really the best way to be doing that? And if, thinking about you, Dr. Ackerman in Minnesota, if you've got somebody in New Jersey that's not going to travel that far, who's now positive, how are we ensuring that that person is going to correctly act upon this? So what I usually try to say is, in an ideal world, the person that's in charge of ordering this testing should be a member of your healthcare team, be that your primary care doctor, your cardiologist, a genetic counselor that you are seeing specifically to get tested. These are now members of your healthcare team that are, as the name implies, they're on your team. They're working with you and for you.
Right. Well, as I see the time, and wow, it went by fast.
Oh my goodness.
It's really been great having you, Brittany. And I think helping us get the word out on this November month of Family Health History Month, I appreciate it. I appreciate what you and your fellow genetic counselors do here, there, and everywhere. So thank you. We can't do it without you. You're vital members of the team. I'm going to give you the last word before I let you go, and then I'm going to give some final summary comments and some announcements for our next get together. But what one or two or three things you want to make sure that anybody who's listening to your sound of your voice can act upon here in Family Health History Month?
Let's say use the opportunities that you have meeting with relatives over the holidays or at other times to share both your diagnosis and gather that family history information. If you have had genetic testing in the past, be sure that if there are relatives that still haven't pursued that you follow up with them and check in and encourage that again. And if you have been hesitant to do genetic testing in the past because of concerns about access or cost, know that there's been a lot of improvements and strides from the genetics community to try to lower those barriers. So if that's something that you've looked into in the past and weren't unable to pursue, don't think that window of opportunity has closed for you. There may very well be, other ways for you to get that testing done now that weren't available the last time. So this is very much not a static field. Things are constantly in motion in genetics. So be sure that if you've had testing a long time ago, that you have access to that report, that if you are switching providers, moving, relocating, that test is traveling with you, because our genes don't change, but our interpretation and understanding of the health risks does over time as we get smarter.
That's fantastic. Well, Brittany, I'm going to let you go. Thank you for taking the time out.
Wish you so much for having me.
A happy Thanksgiving, and we'll be sure to have you rejoin us again. So thanks, Brittany.
Absolutely. Thanks so much for having me.
And Aaron, this brings us to a wrap, everyone, of our 78th SADS live session. I know some good questions, really good questions came in. And Natasha, if you're there, I am going to make yours the very first one that I take when we join each other again in 2 weeks on December 3rd for the 79th SADS live program, which is going to be our question and answer time. And Natasha, I'm so sorry about the death of your husband. We'll take your question first, as give you a sense of the action steps for the rest of your family. And then some of the other questions that came along, we will grab those and do those. But this Family Health History Month is such an important month, and I thought Brittany had some great things to say, and for us to have a bit of a to-do list this coming holiday season here in the United States. So we'll be back together in 2 weeks. In the meantime, in 6 days here in the United States, we have Thanksgiving Day. And so when you and I celebrate that, it's a crazy year, of course, but we still have much, much to be thankful for, and I am. And so take a moment, think what you should be or are thankful for, count those elements, an attitude of gratitude, as they say. I'm grateful for you, grateful to have you as part of our life with the SADS Foundation. So all the best to you. For those who want, then, before we meet in 2 weeks, there's a program on Tuesday, November 30th. Jot it down. Tuesday, November 30th, 7:30 Eastern Time. You'll be joined by another genetic counselor. I like her a lot, Heather McLeod, and be giving a lecture, a conversation, a webinar on what's in your genes and not your blue jeans. So what's in your genes, Genes, and you will enjoy that a lot. And so until next time, be well, everyone. Blessings to you all, and have a happy Thanksgiving.